Good afternoon, everybody. Welcome to our Target BP Recognition Evolution Attestation Workshop. My name is Rebecca Alicki. I'm a National Outpatients Programs Consultant and for the American Heart Association, and I am joined by my wonderful colleagues, Liz Montgomery, AHA's best data analyst for health IT, and Allison Smith, a public health expert and initiative director for Target BP. Before we get started, I do want to note that these slides and recording will be available on Target BP shortly following the event. Very quickly, we are running the accessibility features for closed captioning. You have the ability to manage these settings down at the bottom of your screen. Just look for that closed captioning button. You can either pop this out and have a running transcript on the side, or you can change the size or turn it off if you're finding it's in the way. We will have the opportunity at the end for an open discussion. However, we will be pausing after each section to take some questions. So feel free to ask questions as you have them, and we will be sure to answer them during those breaks. Please utilize the Q&A function for all questions, and we will answer them throughout the event live or via the Q&A box section. Also, the chat function is a great way to interact, share your comments and thoughts. Please keep a lookout here for resource links. Our agenda for today will include a brief overview of the new attestation questions, followed by a breakdown of each of the expanded pillars in the Target BP initiative. As I mentioned on the previous slide, we will pause for questions related to each of these pillars at the end of each of those sections, and wrap up with an open discussion and an opportunity to answer anything we might have missed earlier in the agenda. So with that, I will pass it to Liz.
Thank you, Rebecca. Let's begin. We can move to the next. Oh, no, there we are. Let's begin with some key points about the logistics of data submission and our new questions. First, each new question that we'll be discussing today is asked in a yes, no, unsure format. We ask that you answer these to the best of your ability, as this will be creating a baseline that will be used to finalize new award criteria. I do want to emphasize that we are asking these questions in a dry run format this year, so they won't affect your awards in 2024, but there will be new award criteria in 2025. The deadline to submit data for an award this year is May 17th at 11:59 p.m. Eastern Time, and we've also listed other time zones here just to give you a reference point. There's a snapshot report that is pulled 1 minute after the deadline, and that's where we base our awards from, so it's very important to meet that deadline. Finally, we are here to help and support you and encourage early questions and early submission. This will allow our staff to have greater capacity to troubleshoot common errors or tackle nuanced questions. And the AHA's Community Impact Team is here to provide one-on-one support for your data submission. And we also have additional options for further quality improvement support. We can go to the next slide. So to give our conversation today a little bit of context, I'd like to share a little bit more about Target BP, which you can also find in detail on our new About Us page. The initiative was launched by the AHA and AMA in 2017 in response to the high prevalence of uncontrolled blood pressure. And together we've committed to work with healthcare organizations like yours to advance equity and improve blood pressure control. We do that by leveraging AHA's guidelines, scientific statements, and the AMA MAP framework, which helps care teams organize their approach to providing evidence-based care. And that framework includes measuring accurately, acting rapidly, and partnering with patients, which we'll say many times today. We also assist healthcare organizations in your QI efforts through the resources available on Target BP and the support of AHA and AMA. We know that quality improvement is a journey, and we recognize that organizations have dynamic needs, preferences, and capacities to prioritize and focus on hypertension control. And that's why we have different ways that you can engage with us and be supported. So on the left, we've emphasized the self-guided approach to Target BP. So that's through our website, where you can access our tools, including practice assessment tools, our professional education, and our patient resources. In the center and on the right, we show both how the AHA and AMA can further support your QI journey. The AHA team is ready to meet you where you are, both with national connections and local one-on-one quality support. And the AMA's MAP Hypertension QI program provides a clear path to significant sustained improvements in blood pressure control. And finally, the reason that you're probably here today, Target BP also recognizes healthcare organizations annually with our Achievement Awards by celebrating those who are committed to improvement and those who adopt evidence-based activities, as well as achieving high control rates. So next slide. So today we are focusing on the expansion of our evidence-based BP activities, which is visualized here and was announced in our July 2023 webinar. And we're dropping a link to that in the chat. This model basically takes the measure accurately questions that have been included in the past 3 years and builds upon that for a broader roadmap that includes the rest of the MAP framework. So adding Act Rapidly, Partner with Patients, and also 2 additional important focuses of Target BP, which are SMBP and equitable health outcomes. So we can go to the next slide. Each of these new pillars, as we're calling them, includes 6 questions on that topic. It's a lot of words for one slide here, but you don't need to read everything right now. This visual demonstrates, though, that it's a consistent approach, each including elements of institutional policy, practice assessment, and specific content associated with the strong scientific evidence to improve blood pressure control. And on our next slide, as we begin to dig into frequently asked questions and live questions, we wanted to ask, what pillar do you have the most questions on? Is it Act Rapidly, which includes the treatment algorithm? Is it partnering with patients, which has a lifestyle focus? Maybe it's self-measured blood pressure or equitable health outcomes, where we're asking you about stratification of your data. Maybe it's all or none of the above. So I'm going to take a second here, let everyone answer that poll. See, we're getting a pretty good response, but they're coming in quick. A lot of all of the above, which is good because we are covering all of the above today. All right. Maybe give it just 2 or 3 more seconds here. All right, it looks like second to all of the above is SMBP and then Act Rapidly. And we'll keep that in mind as we move forward. We can go ahead and close out of the poll and move to the next slide. But we look forward to answering any of your questions. And if you didn't get a chance to participate, please feel free to drop that in the chat and say, I really want to ask questions about this pillar. But moving along, so last fall, organizations were invited to participate in a survey on these new questions. We asked if and where the new criteria would help your organizations, and we were really motivated to see that overwhelmingly there was a positive reaction. We heard that the #1 reason to participate in Target BP is to improve patient outcomes, and that these new attestations would really help to focus quality improvement priorities. Next slide. We also asked the new questions themselves in full to gauge current achievement levels. On average, about 3 out of 6 attestations were being positively attested to in each pillar. Respondents did share that they would need additional professional education and practice tools, which we have been aiming to provide in our monthly newsletters and other communications, and we will continue to build our library of resources. And just wanted to note one quick thing to remember is that we really are here to support you. So if you're looking for a specific resource, please feel free to share that in the chat, the Q&A with your other questions, or reach out to our team after the webinar and we can see if we have that in pocket ready to give to you. But with that, we'll get into the details and I'll pass it over to my colleague, Allison.
Thank you so much, Liz, and thank you everyone for being with us today. We're delighted by your interest and enthusiasm in this evolution of our award achievement program and the attestation questions that will support it. So Without further ado, we're going to dive into our first pillar. And as Rebecca outlined in the beginning, we'll sort of walk through each pillar and then pause and have some time for Q&A and move on to the next and the next. And we also will have some additional Q&A time at the end for any lingering questions. So if you can direct your questions to the Q&A function, we will queue them up as quickly as we can. So I want to start with this overview slide of the Act Rapidly attestation criteria. And what you'll see the pattern unfolding as we go across each of the pillars. There's a policy element, a practice element, and then the substance of that pillar relates directly to guideline directed care. So beginning in Act Rapidly, where the emphasis is on treatment intensification, we want to recommend the use of a treatment algorithm. That's the policy element. And that may come in the form of a protocol, standing orders, algorithms. Different organizations call them different things. But the spirit is to define a standard of care for diagnosis and treatment of hypertension. The practice element and the attestation criteria here are about monitoring whether or not your team is adhering or following that guidance in general. We know not every patient fits perfectly in every algorithm, but to assess for general acceptance and adherence to that standard of care. The remaining 4 attestation questions really relate to the substance of what's in that algorithm. And we'd want to see that it specifies a treatment goal of less than 130/80 for adults with confirmed hypertension and known cardiovascular disease or CVD risk, or a 10-year ASCVD event risk of 10% or higher. And I'm going to talk more about the numbers in a minute. We'd also want to see that algorithm prompted providers, clinicians to intensify treatment if a patient is not yet at their goal. For example, adding a medication class. The next is to use strategies to improve medication adherence. So that could be using single pill combination therapies, having 90-day prescription refills, or synchronizing refills with other medications, things like that help improve medication adherence. There's a whole scientific statement by the AHA about medication adherence strategies and hypertension control. So lots of great guidance there. And then the last element is asking whether or not your treatment algorithm prompts follow-up for patients within 1 month if they're not yet at their blood pressure goal. So that's sort of the overview. We have outlined in some of our supporting documents the scientific rationale and the evidence base for each of those attestation criteria that you can read in more depth. And most come directly from the 2017 ACC/AHA guideline on hypertension control. And then I also want to highlight one of the great resources available to help your team, and that's the Act Rapidly Quick Start Guide, which helps you assess your practice, provides on-demand webinars with CME and CE credit to strengthen your team's knowledge and skills about treatment intensification. It has links to some example algorithms and other practice tools. So I want to highlight those resources for your exploration. I do want to spend a moment on a frequently asked question about all of these numbers that we're seeing, 120, 130, 140, what do they mean? How do they count? And so I just want to break it down into thinking about, first we diagnose a patient with hypertension, then we move into treatment, and then we evaluate our performance as an institution in how we're able to care for patients with hypertension. And so starting with the first column of diagnosis thresholds, based on the 27 ACC/AHA guideline, you've probably seen that rainbow chart before that really describes the different thresholds that clinicians use to diagnose different stages of hypertension. So normal being less than 120 over less than 80, and so on. So that's for the numbers that are recommended for use in diagnosing hypertension. And then we move to a treatment goal. These are for individual patients who have a confirmed diagnosis of hypertension and known cardiovascular disease, or they have a 10-year ASCVD event risk of 10% or higher. The recommendation is that they are treated to a blood pressure that's less than 130/80 millimeters of mercury. So that is a treatment goal. And then lastly, in the last column, we're talking about performance measures. So the National Committee for Quality Assurance, a national institution that defines performance measures that are for reimbursement purposes and other quality measurement purposes, they set the standard. We use CMS 165 or MIPS 236, which is the blood pressure control performance measure, and it's used to evaluate the performance level over looking at a patient population. And the way that they specified that measure, it looks at patients who have hypertension and have their blood pressure controlled to less than 140/90. And this is a very familiar metric that's used in UDS reporting, other insurance reporting, and that we have used from the beginning of Target BP in determining when you submit your data for your gold or gold plus status for organizations who have their blood pressure controlled at a rate of 70% or higher. So sort of three different sets of numbers for three different reasons that you may see in these materials. So let me just clarify one other point, and that is that we use 140/90 for this performance measure, the NCQA performance measure, when submitting your data for award achievement to determine whether or not you've achieved gold or gold plus status for organizations who have control rates of 70% or higher. We use 130/80 now when we're talking about these attestation questions. And it's specifically, are you using that? Do you state less than 130/80 as a treatment goal in your algorithm? We're not asking you if you've achieved it. We're not asking you, we're just wanting to see if that's the goal that you're stating in your treatment algorithm. So hopefully that clarifies some of the questions that we've been receiving about the numbers. I will say in the survey that you all responded to back in July and August, which we had more than 200 respondents, which was extraordinarily helpful to hear and learn from you. Over 62% of you already have a treatment algorithm, but the content of that may vary, and it may not quite align with all the elements that are included in the attestation, which represents an opportunity for improvement. You did reflect some confusion and debate over those thresholds, so hopefully what we just walked through will help in that regard. And you also identified the need for more provider education and practice tools. And so I've outlined some. We will continue to work on providing more as this year unfolds and into next. So with that, I want to pause here. These are the actual attestation questions that you will see in your data submission. Again, as Liz mentioned, the answers are yes, no, or unsure, and we'd encourage you to answer to the best of your ability because it'll help set a baseline in this dry run year, but it also help inform us where you're perhaps needing more resources and support. So we really appreciate every effort to answer to the best of your ability in this dry run year. So I think with that, we're going to pause for a minute just to see if there are any questions or comments that have come up in either the Q&A or the chat. Rebecca, anything so far?
Yeah, we have one question. A question about the CMS metric. Can the value that is obtained from automated office blood pressure measurement or AOBP be used for this metric? This is usually an average of 3 readings taken 1 minute apart.
It's my understanding that both AOBP and SMBP readings can be used and qualify for reporting in that metric, so long as they're obviously documented in the medical record. I know Liz is also one of our measure and data submission experts, and I don't know if there's anything you would want to add, Liz, to that response, but I know that the specifications did allow both for the documentation of home measurements or office measurements to qualify. Anything you'd want to add there, Liz?
I think that covers the basics for answering that specific questions, but if you want to see all of the measure specifications, they are included in our data collection worksheet. They call out those kinds of examples specifically, and I'm just dropping that into the chat, so that'll cover those measure questions in more detail.
Thank you very much. Anything else, Rebecca?
Yeah, we have one more. Where can I find the Apt Rapidly Quick Start Guide with links to examples of algorithms?
Great question. And I know one of our colleagues, Crystal, is dropping in links to the chat. And there is a comprehensive, I think she already did, there's one called the Combined Quick Start Guide. We can drop that link in again. That actually has all the quick start guides wrapped up in one document. So it starts with measure accurately, then act rapidly, partner with patients, and SMBP. So you can download that all in one easy document, or you can download its component parts if you prefer. Thank you for that question. Anything else?
That's all we have related to Act Rapidly.
All right. Well, we will also have time at the end if other questions come up.
I'm sorry, Al, there was one more that just came
sure.
in. So sorry. So for the denominator patient population, would patients who the clinic only sees once as the patient is getting connected to another medical home, thinking those would be high if uncontrolled?
So as Liz mentioned, and please feel free to chime in here again with me, Liz, the specifications for the measure and the way that we report control rates have to do with the calendar year. So in the data submission that you're doing now, that relates to the year of 2023, and whether or not a patient was diagnosed, when a patient was diagnosed, either before or during 2023, and when they had visits in 2023 will determine whether or not that patient is counted in your numerator and your denominator. And there's some great examples in some of our support documents that sort of illustrate those scenarios. I don't know. And so I think we will point to those resources. We also covered that at length in our data submission kickoff webinar. And I think the link to that event is also, I think we were also dropping that in the chat if, or Liz can, if not. I don't know if you want to add anything there, Liz, now before we move forward.
I think we can continue forward for time.
Okay.
I'll follow up in the Q&A with a few more details.
I appreciate the question. There's some very helpful resources that spell that out, because there are a lot of different scenarios that will make it clearer with the visual than I can explain without those visuals at my fingertips right now. And I don't want to create confusion. So there's many have that question, and there's some great resources for that. All right, we're going to move on to the next pillar, partner with patients, with the same approach. So the overview of these attestation questions begin with the policy element, like the last, and this one would be adopting a standard of care or a policy and procedure around how we assess and intervene for patients regarding modifiable lifestyle risk factors for those who have hypertension. And then the policy element would be seeing if your team is adhering to the policy or the standard of care that you've set. And then the content of that policy really speaks to two groups of lifestyle risk factors. The first being nutrition, physical activity, and weight. So are we assessing patients for those risk factors? And then are we intervening in some manner and I'll talk more about that in a minute, with regard to nutrition, physical activity, and weight management. And then the last pair of attestation questions is assessing about alcohol and tobacco use. Are we assessing and intervening on those modifiable risk factors? So that's the overview of the partner with patients pillar with regard to lifestyle. Again, we have mapped out the supporting evidence to the hypertension guideline and how each of these elements is associated with risk reduction and hypertension and lowering of blood pressure with those types of interventions. And then we've outlined here some of the go-to resources for supporting your team. This is the Partner with Patients Quick Start Guide that, again, helps you assess your practice, provides continuing education on demand programs to strengthen the knowledge and skills of your team, also helps there's some additional information about self-measured blood pressure in here that we'll get to even more in a minute, but also some great patient education materials. And this is an example of one that's a screenshot here that talks about how so many pounds of weight reduction or so many milligrams of sodium reduction or increases in physical activity will translate into millimeters of mercury lowering in your blood pressure. And a lot of these materials are also available in multiple languages. So encourage you to explore those resources to support your team's success in this space. I want to move on to one frequently asked question, and this actually applies to all of the pillars, but I want to touch on it here. And it's really illuminating some of the intent behind the criteria when we're talking about monitoring or assessing your team's use or practice of a policy and procedure. Like, how well do we translate our standard of care into practice? How consistently? And these are some examples of what we would mean as meeting the intent of that criteria, as well as some examples that wouldn't meet the intent of that criteria. As you can imagine, we want to root all of these criteria in the science, but recognize the latitude and differences across your organizations in terms of your resources, your electronic health record tools, your analytic team support. So we want to provide a variety of ways in which you could affirm or attest, yes to these questions. So some examples might be, let's say you have a policy and procedure that talks about assessing patients for risk factors and intervening to help improve or lower their risk. You could, if your electronic health record has the ability to run reports looking at documentation of whether patients were assessed or whether they were referred to for services in some way, that might be an automated way that you could look to see if your policy was being followed, in practice. Another example, let's say your health record doesn't do that. You could perform a focused manual chart review on a sample of records that would include the care team members who are responsible for performing those assessments and referrals. So those are examples, one a high-tech way, one a lower-tech way, and there are, I'm sure, other examples that you all can bring to the conversation of how that might be achieved. And so I also want to clarify that the standard is not asking you to achieve a specific level of adherence to your standard, but certainly the intent of it is to encourage the use of that data to reflect on your practice and improve consistency and minimize variation in practice, just in the spirit of quality improvement. And then the examples that wouldn't meet the spirit or the intent of the criteria is, implementing a standard of care, but, not looking to see if it was being followed, or not intending to improve performance, only sampling some of the charts of the individuals that are responsible for that type of care, or really, making no effort to evaluate. So those are just some examples of what we mean by assessing your team's performance. And that would apply to any pillar. The concepts here, whether you're assessing adherence to an algorithm, your policy and procedure, or as we talk more about SMBP and equitable health outcomes in a moment, the same concept applies. Some of the FAQs around this particular pillar were about what we mean by interventions, and that we again, as an example, defining this very broadly. That might mean providing a patient educational materials, handouts, or showing them videos about modifiable lifestyle risk factors. It might mean using collaborative communication and goal setting, something that you might document in the health record. It might mean referring the patient to an expert within your practice for some counseling, such as a dietitian or an exercise physiologist or a cardiac rehab specialist. It also might mean referring a patient to an external resource in the community, to a cooking class or an exercise class. Or it might be there are other, really emerging best practices around writing prescriptions for food, fresh produce, or exercise. So those are all examples of interventions that would meet the spirit of this attestation question. I do just want to reflect that a very high percentage of you, 73%, reported having strategies for intervening. There was a wider, sort of a lesser level of performance. Less than half of you actually assessed whether or not you were adhering to your policy. But I think there was an overwhelming enthusiasm that this was a focal point, that lifestyle modification and supporting patients in improvement and lowering their risk is a really important part of patient care and hypertension control. And I think we got a lot of feedback that, like this quote, seeing this as an opportunity to strengthen your team's skills and confidence, and really, leveraging team-based care to make headway here. So And we appreciated that feedback from the survey. So I'll just pause here on the actual attestation questions for Partner with Patients as they will appear in the data platform, and just pause to see if there are any comments or questions that have come up at this point. Rebecca?
Yeah, we have one. If our EMR system does not have the capability to run reports, how many patient charts should be reviewed for the manual chart review if we have more than 1,000 patients with hypertension?
Yeah, the recommendation here and the sort of intent is that if you look at a chart for every person who's responsible, like if your policy spells out that it is, the nursing staff or your clinician team, or depending on, whose responsibility it is to do that assessment and or referral, then I would look at least a chart of each of those individuals would be the recommendation. But each organization has, I think, different standards for, their what constitutes, quality improvement review. So that's some guidance that we can offer as a starting point. Thanks for that question.
Yeah, and I do want to just quickly know, I know that that has been said in the chat, but I do see a couple of people have hands up. We unfortunately are unable to unmute our participants. So please feel free to put all questions in the Q&A box. I am also monitoring the chat just in case, but it's much easier to ask if all of them are all directed to the same place. So if those of you with your hands up that might have questions or comments, feel free to put them in the Q&A box, and I will do my absolute best to answer them, or to ask Allison to answer them live.
Sounds good. All right. Anything else on this pillar at this point?
Not on this pillar. And just again, as a reminder, we will have a few minutes at the end for an open discussion. So anything that we miss right now, we'll circle back at the end.
Great, thank you. All right, well, we'll move on to self-measured blood pressure. The overview of this pillar starts with defining a standard of care and how you prepare patients for success at home in monitoring. So that's the policy element. And then again, an assessment to see if your team is carrying out that policy with a practice assessment. And then the really core components of this pillar in terms of evidence-based practice are training your patient in both measurement technique and the use of the device and the technology itself, establishing a measurement schedule that is evidence-based, and how frequently, when, and how frequently you want a patient to measure their blood pressure. So one of the guideline-directed examples is twice in the morning before medication, twice in the evening, and doing that times 3 to 7 days to create a sample of measures to be relayed. And that's the next one, is receiving those readings from a patient and averaging them to inform diagnosis and treatment decisions. And I'll talk a little bit more about what receive means in a second. And then the last element is using SMBP with 30 patients or 10% of your patients with hypertension, whichever is larger. And this is a unique criteria in this pillar. So to have an SMBP program and to sort of attest to and receive the accolades associated with, we would want to see a systematic implementation of this practice. And so some organizations are very advanced in their SMBP practices. Some don't appear to have the capacity, the bandwidth, or the resources to take it on, and that's okay. And some may be moving in that direction and building a program over time. So this is an example of an opportunity where, we expect room for growth and development and want to highlight the resources to support your success. And so in that regard, again, we've outlined the evidence-based supporting these attestation questions that you can dig into with your team, and just a pile of resources, including the self-measured blood pressure quick start guide. I think there was a question in the Q&A about resources available for SMBP implementation. This is a great place to start. Again, it helps you assess your practice, help build your team's knowledge and skills, provides a lot of practice tools. So for example, In the middle here of these images is a patient education, a training checklist. So your team can think through making sure we get the right device with the right size cuff, that we provide patient with training and materials and recording log and a plan. And then many of you are familiar with this infographic that is written with patient needs and language in mind to help illustrate proper positioning, to help them prepare and find a place that's appropriate to measure in the home. Position, and then also measure and record and relay their readings. There's also this great training video that's available in English and Spanish that's like 3.5 minutes long. Like, there are a lot of resources here that help you to design and build your program. All right, and then so one of the FAQs with this particular pillar is, what do we mean by relaying readings from the patient? Again, we recognize there are a range of capacities and practices out there. One of the most important, evidence components of SMBP is getting the readings from the patient to the care team so that they can be used to inform diagnosis and treatment. That's the evidence, one of the evidence points that makes SMBP most effective, that it's used in care. And so that might be written on a napkin or a paper towel and a piece of paper and brought into your clinic and offered to your care team. It might be an elegant, fully integrated transmission of readings from the SMBP device through an RPM platform or directly into your EHR, or anything in between. Those are just, sort of examples from different ends of the spectrum of how manual or automated that relay of information is. So it's just important that the information gets from the patient to the care team. And then the other FAQ we've gotten is around this minimum of 30 patients or 10% of your patient population. And again, the intent is to not just to be able to do this for one patient, but to have a systematic practice or program in effect. You shared with us through the survey that more than 50% of you have a policy to prepare patients, but again, the content of that policy might vary, and there's some opportunities to strengthen that through using these tools and resources. We did hear your comments that some practices have concerns over the cost of devices and the volume requirements, maybe not being scalable at this point for your practice, but also acknowledging gratitude for the resources that we have made available to help design and implement your program and support your patients. I will say that AHA and AMA in our policy efforts continue to advocate in states across the country to help improve the coverage that Medicaid provides for SMBP devices and the reimbursement it provides to practices for providing SMBP care. And we also continue to advocate for that coverage at the federal level. So there are lots of things we're trying to do to make this a sustainable practice for all organizations. So then I'll just pause here. Again, these are the actual questions as they appear in the platform regarding the evidence-based use of SMBP. So I'll ask Rebecca again if there are any questions that have come up regarding SMBP.
None that came in. You did answer live. Somebody had asked if there's any resources available, which you covered. So thank you very much for that, but no additional questions related to SMBP have come in.
Great. I'll also mention that, our colleagues at the National Association of Community Health Centers and Million Hearts are also doing terrific work in the space and have some great implementation toolkits and guides that, we highly, highly recommend that might augment some of the resources that I've described here today. So more, there's a growing number of resources to help plan and design a program and implement and maintain and support patients in their success. So, all right, so the last pillar is equitable health outcomes. We're very excited about this new pillar and really starting with the policy element. There are actually two policy elements in this one because we're trying to identify we're trying to strengthen the practice around the collection of race and ethnicity data and the collection or assessment of social determinants of health. And so since those are kind of different domains and often gathering that may be performed by different team members at different points in the care process. So, for example, race and ethnicity might be something gathered at the point of admission or intake by a front office team member, whereas social determinants might be gathered during a visit by clinical or social service personnel or other clinicians. And so we separated those two out. But again, inviting you to define a standard of care for how you would gather race and ethnicity data and how would you gather social determinant of health data. We also have an element in here to train your teams in how to do that, what it means, what sort of scripting or approaches are considered constructive and collaborative and engaging to patients, because we recognize the sensitivity of some of this information and how and why, and providing patients sort of a safe place to self-report and provide this information so that we can support their care. There's also a practice assessment here to look at your team's adherence to either or both of these policies, should you choose to adopt them. And then the climax, the most important part in all of this, the why, I should say, each step of it matters, but the why is that using this data to stratify your blood pressure control rates by at least 2 subgroups or subpopulations that you serve, and then ultimately looking at that information for opportunities to strengthen care, reduce disparate outcomes. So for example, you'd want to take your blood pressure control rate for your overall patient population, and then perhaps look at it also broken down by race and ethnicity, and see if, for example, patients of Native American, Alaska Native background have different control rates than your overall patient population, if that is a group of patients that your practice serves. And thinking about class-informed interventions that might narrow that gap if a gap exists. Similarly, you might want to stratify your blood pressure control rate, of your overall patient population by a factor like whether or not a patient had insurance or not, or what zip code they lived in. And that might reveal other inequitable outcomes and opportunities to improve care. So again, trying to look at the data and then examine it and take action to strengthen equitable outcomes. Again, we're tying these attestation questions back to the evidence, which includes, it sort of goes back even farther from the 2017 guideline to scientific statements about social determinants of health. The Institute of Medicine has had, back in 2009, had some really informative and clear guidance on the importance of this activity and driving equitable health outcomes. We have some great resources at Target BP and through others. I've noted the Prepare Implementation and Action tool, other Target BP resources to help guide evidence-based and best practices in how you collect race and ethnicity data. So there's a lot more resources listed in our evolution or overview document that you can explore. These are just a few examples. So for the FAQs on this topic, wanting to clarify what we mean by stratification. Again, it's taking your overall blood pressure control rate and then breaking it down by subgroups that might be characteristics like, you're not limited to these, but these are examples that you can look at outcomes by age, sex, gender, or gender identity, by race and ethnicity, your primary language, by insurance status, zip code, or also any social determinant of health, depending on how you assess those factors that make individuals more vulnerable and factors that might interfere with their ability to achieve health and blood pressure control. Things like food and housing insecurity, mental health, and personal safety status or immigration status. Of note, 65% of you already have policies in this space. Fewer of you, 42%, noted that you're currently using that data to stratify and sort of look across different strata of your patient population for opportunities to improve equitable outcomes. We did hear the comments that some organizations are challenged because their health records don't allow them to either capture some of these factors or to analyze them. And so we certainly recognize that may be a room for growth and development that may take time. And we also heard a lot of positive enthusiasm and support for us adding this to the spectrum of attestation questions that will relate to award achievement, to have health equity be a really important component of that. And we also heard the need for more kind of how-tos, some of the policy and procedure examples and templates. And so those are some of the resources that we'll want to highlight, those that exist, and add to those over time. So we appreciate that feedback. And then again, landing on the actual questions as they appear at the platform, and really wanting to invite any comments or questions that may have come up with regard to health outcomes.
Yeah, so we have one. How often do social determinants of health need to be assessed?
So we don't specify that in our attestation criteria. That's an example of something where, as your organization thinks about what your standard of care should be, that's what you would write into your policy and procedure, and that's what you would then assess your performance, and compare to. So for example, you might say, every time a patient is admitted new to our practice, we might assess their social determinants. And then if they have risk factors or social determinants that, are something that, you want to follow over time, then you may reassess them at every visit or annually, or you might also, revisit it annually for any patient who has a diagnosis of hypertension. That is a standard of care that your organization would need to set, for itself. But it's a great question, and one that, setting those standards of care and expectations for your team, those are decisions often made, best by a multidisciplinary group, and thinking about the nature of your patient population, the capacities and skills of your staff, and the means that you have to assess and implement that. So a great question, and one that where we want to provide organizations latitude, just because you're all so unique in who is providing care in your institution and to whom you are providing care. So anything else, Rebecca?
Not related to equitable health outcomes, but we do have a general question. If I'm
Sure.
just going to pause for just a half a second, just to make sure that any questions related to equitable health outcomes are answered. And I don't see any additional ones. So I guess moving forward, if you are okay with answering more general questions.
Yeah, absolutely. Whoops, one thing I'll just, before we dive in here, this is just an example of how many resources we've already curated to support each of the pillars. So and this list will continue to grow. This is available in the documents that we've shared in the chat. And I'll just pause sort of using this as our wallpaper and background for any other questions that you may have about any pillar specifically, any attestation questions specifically, or just any general questions about this data submission cycle or the attestation question. So Liz and I are here ready to field any other comments or questions.
So we had a question come in. Do we have to answer yes to all items in a pillar to receive credit for that pillar?
So that's a great question. In the existing that have been in place for 3 years now, the Measure Accurately attestation questions, you're probably familiar that if you answer 4 out of 6 of them, that will make you eligible for the Silver or Gold Plus awards associated with that pillar. We expect that same concept will be applied to these new pillars. That said, first looking at these just as these are all evidence-based practices. The guideline recommends that we do all of these things. And so we'd really encourage you to strive to do, all 6 in every pillar, recognizing that, you may not be able to achieve all of them at once. Your organization may choose to tackle one at a time. And that's certainly, the prerogative of each organization to prioritize it's the way it, it wants to prioritize quality improvement opportunities, as well as think about how to strategize around their award achievement. Once we have this dry run information during this data submission cycle that ends May 17th. We are going to reflect on these dry run answers and help us to inform how this will actually translate into new award opportunities. And so we will, I believe our plan is in July, correct me if I'm wrong, Liz, of this year, announce how this will translate into awards for 2025. Because remember, this year is a dry run. We would love to help you document your baseline. We'd love to learn from your baseline to inform like where we can provide more help and support, and how we might set those award levels for 2025. So I don't know if you want to add anything there, Liz, or clarify.
I think you covered it. We'll be sharing once we have those details everywhere. So we will probably have a webinar in the summer where we'll announce it, really dig into those questions and clarifications. But I also want to say that some of the first places that you can look for this information is in our newsletter. And we really encourage you to sign up for that to make sure that you don't miss out on any of the new information regarding the pillars and the awards.
Thanks. Anything else, Rebecca?
So, no, we just have a question regarding slides, when that will be available. The slides and recording will be available on Target BP very shortly. So feel free to look out for those in the coming days. We do have I know you answered it a little bit, but I'm wondering maybe you'll be able to expand a little bit further. Why should we answer these questions in 2024 when they don't impact the award status this year?
Thanks. We realized that we went from 6 questions to, we just added 24 more, and we debated long and hard. Do we do one pillar at a time? And the feedback that we've gotten through many of our dear colleagues in the community impact team at AHA, who work directly with many of you, is that it really made sense to sort of lay it all out there and create a broad space and a clear array of options, and space to sort of focus on all of these areas that we know from an evidence base can drive improvement, and that we want to recognize through our award achievement program. So we recognize it's a lot to take in year one, and that's why we made it a dry run. We think there's a great opportunity to respond to the best of your ability this year so that you can have your baseline in the platform. We've heard a lot of organizations who've been participating in Target BP's annual award achievement program where they love going into their dashboard and seeing their performance change over time. And we soon hope to have additional information where you can track your attestation question over time as well. And so looking and helping to prioritize, where you're making headway, where you may have some gaps. And as I mentioned, your answers, just as your answers to the survey helped us prepare some of the materials this year, your attestation answers in data submission will help us figure out where your needs are the greatest, where we should invest our time and resources in providing more support, and how we should set award levels for next year. So a lot of good reasons, but I don't want to, I certainly recognize that it's a big shift. So we look forward to your feedback on the pillars.
And I'll just add that one thing that I've heard, since we started adding the measure accurately pillar, is that returning year over year and seeing those answers are a good reminder of, where you've been the past year, and that can be helpful when you have staff turnover or changes, and it gives you a good baseline where to start looking, where you've been, if you're new to your role, or if there's been turnover in your roles and you see, oh, well, it shows that we have a treatment algorithm, or we have this attested to. Let me go check on that. Let me go look to see what we have, where we can start. So we're hoping that this is a useful tool as you continue to work on these in the coming years. And our community impact staff, as Allison mentioned, were really helpful in, being a voice for healthcare centers as we were thinking about how to structure these. And they're going to continue to be a strong voice in answering questions and building upon the frequently asked questions that, we're adding to the slides and we're building new resources on. So we encourage you to, we're happy to have you here on our national call, but really encourage those local connections as well. And just know that we are listening in there.
Thanks for that, Liz. I appreciate that. Anything else, Rebecca, that you're seeing come in at this point?
Nothing else from our Q&A or our chat, and it looks like you have, in the topic of conversation, have answered most of the general questions. So that's very helpful.
Yeah, I'll just say one other thing before kind of moving to our wrap-up slides then, and that's that, some organizations have asked us where should we start? And I think, every organization approaches quality improvement activities differently. And, I think some organizations start with finding a champion. Do we have a champion of this particular topic on our team? Some organizations may want to tackle one pillar at a time. Some may want to identify where where they have the most progress and they can sort of continue on and build on successes. Some may want to look at where they see the lowest hanging fruit and start having early wins. I mean, those are all very legitimate strategies in quality improvement. There's an art to it and a science to it. And we've tried to lay out the science and also leveraging the MAP framework as a strategy for improving your quality improvement activities. And then, as Liz mentioned in our opening, really laying out additional quality improvement support through the Target BP website in a self-guided way, through work with the AHA team, both at the national and local level, and through the AMA team through its MAP hypertension efforts, and laying out more quality support as well as education tools and resources as the shift that we're making this year to support you in success across all of these pillars. So with that, I think Liz is going to share a few wrap-up slides, and we'll press on here.
Yeah, so just a little bit of a repeat from the beginning to kind of bring into focus. So yes, we'll have those response options of yes, no, unsure. And I think, what we were just talking about really speaks to it's okay if you don't know everything right now. But it's, that act of checking and seeing where we're at. So that's why we wanted to emphasize that. And the awards will not be affected this fall, but your practices in 2024 will affect your awards in 2025, and we'll announce what those changes and criteria will be this summer. But we ask that you get all of your data into the platform by May 17th at 11:59 p.m. Eastern Time if you would like to be eligible for an achievement award. And as always, please continue to ask your questions and submit data earlier rather than later. You can go to the next slide. We wanted to highlight a few of our, I'd say, essential resources when you are getting started with these new evidence-based activities. So this top link for a resources and examples document is, I think, our newest one on here. And this goes into depth on all of our pillars, including measure accurately, and it lists the full questions. It also lists examples of does this count, does this not count, similar to the graphic Allison shared earlier with a check mark and an X, and along with the rationale and scientific guidelines on that question. We also have the overview document, which gives background into why we decided to make these changes, and a recording of our announcement last summer. But just remember that we are here to help. If you do not have a local contact yet, please feel free to reach out via our Contact Us form. We're happy to answer your questions, get you connected in any of the ways that Allison was just outlining that we have available to support you. But Thank you so much for joining us today. Oh, and one more thing, we do have an additional office hours. All of the Achievement Award programs and initiatives will be included on that call, and that is on March 13th. So we invite you to join us there as well.
Thank you again, everyone, for joining us today. I also want to thank my colleagues, Rebecca Olicki, Liz Montgomery, Crystal Amato, and Melissa Arundel in the background, making all the technology work along with Ms. Rad Basic. So thank you again for all you do every day and for your continued engagement in Target BP.